Today I'm going to be talking to you about a project, a perinatal project, which aims to map the delivery of interventions for chronic hepatitis B, influenza and pertussis. And I'm going to be focusing on chronic hepatitis B just in the interest of time and the interest of the audience, but also very happy to, if anyone has any questions about influenza or pertussis, happy to take that on. So this study was funded by the Department of Health and had 3 different studies. So the first one was a community study which explored how mothers with hepatitis B understand and experience PMTCT, which is the prevention of mother-to-child transmission. The second one was a data linkage study which estimated the uptake of hepatitis B mother-to-child transmission intervention, so predominantly vaccinations. And the third study was a system mapping study which looked at hepatitis B, influenza and pertussis barriers in terms of on a system level, so looking at service delivery. So I'll quickly go through, start with the community study, and I'll be going through, just in brief, some of the methodology, the key results, and then key opportunities to improve care for pregnant women. And there will be some Q&A at the end, but please feel free to interrupt and just put your hand up and we can go through any questions together. So we know that about 800 women with chronic hepatitis B give birth in Victoria every year, and that there is evidence of local mother-child transmission both here in Victoria and also in other states. I think the previous speakers have touched on that mother-child transmission can occur and that children who are exposed to hepatitis B perinatally have a higher risk of developing liver cancer. Mother-child transmission is also a priority, both globally and in Australia. It's part of the triple elimination of hepatitis B, syphilis and HIV, and also part of our national and state strategies. So just to give you a bit of a methodology, we were really interested in women's lived experiences, so what information was provided to them, how they understood that information most importantly, and how they understood the prevention of mother-to-child transmission and vaccination. So we recruited women with hepatitis B. This study was co-designed with mothers with hepatitis B through a community advisory group, and we recruited women through purposive and snowballing strategies, so basically targeting and word of mouth. And I'll also like to acknowledge that this study was in partnership with Liverwell and also Jack Wallace through the Burnett Institute. So we interviewed 16 women, 11 were born in the Asian region and 5 born in the African region. 7 required an interpreter, overall speaking 10 languages. And 12 of the women had primary and or secondary education. So I'll be going through some of the key themes that came out of this study. And so the first theme was about being diagnosed, and women described the experiences of what that was like. And most women were diagnosed predominantly either pre or post-migration to Australia or during birth. And as you can imagine, pregnancy itself is a very stressful time for families, particularly women. And on top of that, women experience the shock of being diagnosed with a chronic disease. As Tham explains here, that she was diagnosed during pregnancy. And also Arif here talks about that, little to no hepatitis B information were provided to women, and this was particularly at maternity services. So women often were referred to the specialist. It was almost like, great, you've got Hep B, it's great that you've seen someone else kind of by. And that's how the women described most of their experiences. Understanding of hepatitis B varied among the participants, with most having poor understanding of hepatitis B, as explained here by Fatu, who understands that hepatitis B progresses in time, but she wasn't sure that the treatment was available to her. And also Yuri here talks about that she was told that she's a carrier, but she wasn't actually sure what that meant for her. And for those people who don't know, it's a really outdated term of telling people that they have hepatitis B, which obviously we don't advise anyone that they're carrier anymore, because often in the past, people were told that they're carrier, and which meant, don't worry about it, you don't have to worry about hepatitis B. So it's really sad to see that this term is still being in use. Few people understood the relationship between chronic hepatitis B and liver cancer, so they didn't really understand the long-term impact of what it means to live with a chronic hepatitis B. Also, understanding of vaccination and transmission varied among women, and most understood the basic principles of the vaccination. So, for example, as Yuri says here, it builds the immune system. But also some women didn't understand vaccination that well and were confused about the uncertainty about the purpose of the vaccination. Excuse me, 2 women were unaware that the infants were actually vaccinated at birth, and they confused the heel prick that is conducted at birth to be hepatitis B testing, which we know it's not. It's for other rare medical conditions. So then when I probed about vaccination, they were really confused at me and saying, why are we talking about vaccination? My child was tested at birth and they don't have hepatitis B, so I don't have to worry about it. Which obviously we know that that's not the case. 2 women were also advised not to breastfeed their infant. As Amala describes here, she was advised not to breastfeed for the first 24 hours, which again, we know that breastfeeding is safe during breastfeeding. So I think there's a lot of work to be done around education for both mothers and the healthcare providers and supporting them. There was also low hepatitis B discussion with women and information provided to them. As Fatima explains here, that she was tested at each pregnancy, but wasn't provided much hepatitis B information. There was also low health literacy and English proficiency among women. And as Amala describes here, even with an interpreter, she sometimes found it really hard for her to understand. And sometimes I think that's the challenge, where sometimes people think, oh, if I want to communicate, I'm just going to provide an interpreter. But I think this just shows that even with an interpreter, hepatitis B can be so complex, and sometimes it's really hard to communicate in native languages where even the word for hepatitis B doesn't exist. And I think it just shows that there's still a long way to go around interpreting and education. There was also low hepatitis B vaccination testing advice provided to women. We know that infants born to women with hepatitis B should be tested post-vaccination, just to make sure that the vaccination or mother-child transmission has been averted. But we know that's probably not happening to the level that it should. But the few women that were advised to test their child faced some barriers around this. So Rosa tried to test her child a few times, but she was unable to because the pathology clinic didn't have enough nurses present and was instead advised to go to the hospital. There was also mother-child transmission concerns, as Thode explains here, that both her and husband have hepatitis B and she doesn't want to pass it on to her children. And San explains here that she wanted her baby bathed before vaccination to reduce the chance of the bodily fluids being carried by the vaccination needle. So she was worried about passing hepatitis B to the baby, and I think women who although all their children were vaccinated, they were still worried about transmitting hepatitis B to their child, and which meant that they were not modifying their behaviours at home, whether it meant worrying about sharing nail clippers or toothbrush or things that really they shouldn't worry because their child's already vaccinated. But that understanding of vaccination was poor. And Fatu explains here in the last quote that she's worried about hepatitis B and its long-term impact on her. And I think that came from the idea of, hepatitis being an intergenerational impact. Often, if, the mother or the father or child had it, it meant people knew within their family someone else had it, whether it was their community, their friend, or their families. So in summary, hepatitis B diagnosis occurred at a really complex time in a women's lives. There was little to no hepatitis B information provided to women, particularly during diagnosis and postnatally. There was also a poor understanding of hepatitis B, particularly around vaccination. There was concerns of mother-child transmission and also liver cancer. And there was also poor social and emotional support for women. Women often describe that the focus is on the baby and not so much on the mother. But then there was also no relevant hepatitis B and pregnancy resources provided to women. Are there any questions before I move on to the data linkage and analysis study? No, okay, move on. So just to give you a bit of a background, excuse me, we linked large data sets. So the VPDC, which is the Victorian Perinatal Data Collection, FES, which is the notification system for the Department of Health, the VAAD, which is the Victorian Admitted Hospital, so the admitted data set, sorry, so this is the hospital data set, and the Australian Immunisation Register. And the VPDC, basically what we found was that there were almost 700,000 mother-infant pairs identified. And of those, less than 1%, so 0.76, had hepatitis B. And within that, what we looked at was hepatitis B birth dose uptake. So I'd like to know, so this is looking at only 2017, and prior to 2017, timely birth dose was recorded as less than 7 days. However, that changed in 2017, where timely birth dose was less than 24 hours to align with global recommendations. So the first bar is looking at the general population, and as you can see, so the dark blue is less than 24 hours. Light blue is within 24 to 7 hours. Green is less than 7 days, and red is not received, and grey being not stated. So as you can see, the first bar is looking at the general population, and timely birth dose in 2017 was about 85%. And then if you look at the second bar is infants born to mothers with hepatitis B. And as you can see, timely birth dose, again being within 24 hours, was just above 95%. And that should really be 100% to prevent mother-child transmission. And what that really means is that in 2017, there was 1 in 20 infant born to women with hepatitis B who did not get timely birth dose. We also looked at timely birth dose by hospital. Again, this is just looking at 2017. And what we've done is grouped hospitals, the top 20 birthing hospitals in Victoria. And as you can see, what that really, this graph really shows is that most hospitals are not meeting the targeted timely birth dose in Victoria, particularly the two middle graphs, which show the grey being the number of births and the blue being the number of hospitals, is that those hospitals have the highest number of births in Victoria. And as you can see, it's between 90% to 89%. And there were 2 hospitals who had less than 70, I think it was about 64% of a timely birth dose. This is looking at, again, similar graph, but it's looking at infants born to mothers with hepatitis B. And as you can see here, a timely birth dose uptake within hospitals varies across hospitals. And again, this should really be 100%. Most of these hospitals should be achieving 100% of timely birth dose, but only 9 hospitals were able to reach that target. We also looked at factors associated with hepatitis B birth dose uptake within 7 days. And infants born to mothers with hepatitis B were more likely to be vaccinated if the mother was born overseas, but less likely to be vaccinated, timely vaccinated, if they were either born in private hospitals or if they were underweight. This is looking at the recording of hepatitis B status across the different health systems. So as you can see, there's a variation between FES, which is the notification system, and VAAD, which is the hospital system. And about 40% of hepatitis B status notification was not recorded across all three health systems, which obviously can be really, I think, dangerous if we're wanting to record and do follow up for mothers, that this is not being recorded across the system. Uptake of hepatitis B immunoglobulin is really hard to comment on because we don't record it well. What we found is that there was poor recording between the period of this study, and we only found 129 administered to infants born to mothers with hepatitis B. Again, I think this is likely due to just a recording issue. But what we found was that evidence of local mother-child transmission, so 8 notifications were found of infants living with hepatitis B. And again, I think this is we can assume this is an underestimate because we don't systematically record or test children after vaccination. Are there any questions? I know I'm going through this pretty quickly, but are there any questions before I move on to the last study? Chloe?
It's quite a simple question, Nafisa.
No such thing.
I was just thinking for the people in the room as well as myself, what's a timely birth dose? Is it a timely birth dose of the immunoglobulin? Is that at the same time as the birth dose of the vaccine?
That's a great question, and apologies I haven't clarified that. So timely birth dose is 24 hours. Timely hepatitis B immunoglobulin is within 12 hours.
Okay, thank you.
Any other questions? Otherwise I'll keep going. Okay. So for the system mapping study, we were really interested in how interventions, so for hepatitis B, influenza and pertussis, how these interventions are delivered to Victorian pregnant women and their infants. And with that, we've done consultations with key healthcare providers, some of you are in this room, just to guide the development of 2 online surveys. So this first survey was for maternity unit managers at birth and hospitals, and we were really interested in health service level barriers. The second survey was for healthcare providers involved in the care of pregnant women and their children, and this was in the community, so GPs, nurses, and we really wanted to understand implementation level of service delivery. And so I'll quickly start with the birth in hospitals and then to the healthcare providers survey. So just to give you a bit of a background of who participated in the survey was sent to all Victorian birth in hospitals. So at the time that was 56 hospitals, and about 61% participated. And as you can see, most of them were public hospitals across Victoria, and the respondents were maternity unit managers who were exactly the right people we were targeting. In terms of hepatitis B care, 53% said that they had a infectious diseases specialist at their service. And we asked if there was a standard procedure to confirm a woman's hepatitis B status at their service. And as you can see, what we found looking at the green arrow is that about 11 services relied on verbal report from the women instead of checking instead of having like a standardized procedure or checking BOS or other health records, which we thought was really surprising. We also asked if there was a standard protocol for seeking consent from mothers for the administration of birth dose and HBIC. So birth dose is the blue and HBIC is the orange. And as you can see, there are some services who don't have a standard protocol for seeking consent, which really correlates with what we heard from the lived experience study of women being confused whether their child was even vaccinated or not. So the key barriers for hepatitis B birth dose and HBIC, as you can see, reported from healthcare providers, was that women declined vaccination. There were vaccines stock out of HBIC in 3 birth-in hospitals. And there was one hospital that said they actually do not routinely stock the vaccine, so they would need a pre-order, which can be challenging, I would presume, because you would have to know if you would be getting a woman giving birth at your hospital in terms of hepatitis B status. We also asked about guideline-based care delivery barriers. So the previous one was focusing on hepatitis B birth dose and HBIG. This is looking at the sort of the cascade of care. And as you can see, the key gaps for that was there was no infectious diseases specialist available, and this was predominantly regional Victoria and also private hospitals. And there's obviously challenges around staff being not adequately being trained in hepatitis B, lack of communication between services, so this is primary and tertiary. I'll now move on to the healthcare provider survey. So 140 people responded to the survey. 57 of those were from hospital setting, and most of them were from public hospitals. And there were 83 participants from community setting across Victoria. We asked, again, similar questions around confirmation of hepatitis B status, and again, looking at the green arrow, there was a large number of services that relied on verbal report from the women. We then asked if a pregnant woman was positive for hepatitis B, what were the next steps at their service? And most services either referred women to another service or looked after them within their service. But as you can see at the top two bars, 4 services that said that they do not actually provide care for pregnant women with Hep B, and 2 said that they do not take any further action. Again, yep.
So out of the group of people that I said the time, 3 of us were all told we were Hep C positive as well as non-A, non-B at that time. So when I'm looking at that and interventions that take place, can you explain to me the difference between testing positive? Is that, as in, they said we were positive for Hep B at that stage, but that's not actually positive, is it? That can, as in Hep B active still in my system, it meant that that grey area of not knowing. Can you explain a little bit? I'm not probably articulating that right. No. But it was like finding out that you're positive. So I was Hep B positive. I tested, and that was while I was pregnant when I found out those diagnoses. None of these. So is that when these interventions take place? Is that?
So that's a great question. So we asked so a pregnant woman comes into your service, how do you actually know whether that person has hepatitis B? And usually the guidelines are we should test all pregnant women, irrespective of whether they've had a test before, hepatitis B test. But what we've asked, what healthcare providers are saying are, most of them test, but some of them rely on verbal report from the woman. So they would ask the woman, do you have hepatitis B? And yes, that's a positive. Again, there's a lot of discussions around what that actually means, because sometimes you can be told that you are positive, you can be diagnosed, so technically do the test, but women might not understand what that actually means. Like it's one thing to be tested, but how the quality of that conversation is unknown in terms of how well the person understands, whether they use teach back and the patient actually understands what that means. Does that answer the question?
Yeah.
Yes. Yeah, and as you can imagine, I think for anyone, it's for a chronic disease, it's really hard to understand. But if you are particularly don't speak English, or English is not your first language, or if you're just pregnant and there's hormones flying everywhere, you don't actually remember what you've been tested for or what vaccination you've had. So I think the takeaway from this is you just should test all pregnant women. We shouldn't be relying on their recall and what information they can remember. So again, we asked similar question around if there's a protocol for hepatitis B birth dose and HBIG administration. And again, as you can see, there are some hospitals that with the orange bar that said they don't have a protocol for consent. So this graph is a little bit busy, but bear with me. We asked healthcare providers' confidence around hepatitis B testing, treatment, and ongoing care for hepatitis B. So we asked on a scale of 1 to 5, 1 being I'm not very confident, 5 being I'm very confident. And as you can see at the first graph, most healthcare providers were confident that all pregnant women are tested or offered hepatitis B testing at their service. But then that confidence declines as you go through the cascade of care. So the second bar being, confidence that all pregnant women receive DNA testing in the second trimester. The third bar at the bottom being all pregnant women with a high viral load are prescribed treatment in the third trimester. And the last one being women are linked to ongoing care. And I think that confirms sort of what we know of the cascade of care in terms of gaps in clinical care for women and their infants. In terms of barriers for both dose and HBIC, again, they were quite similar from the maternity birthing hospital survey. And the key barriers being, there was no standard order, or there were challenges and gaps around healthcare providers' training and knowledge of hepatitis B. And also communication between services, vaccine stock out, which I think is critical to preventing mother-child transmission. Barriers of guideline-based care was again lack of communication, no ID physicians, and also again gaps in healthcare training and awareness. And some of them said all of the above. So this is my last slide, and to summarise it all, I think there are opportunities for system coordination and strengthening, particularly around developing a statewide care delivery protocol. So healthcare providers said, we've got enough guidelines, we don't need another guideline. What we need is implementation policy. So irrespective of which hospital you give birth, the care should be the same. And I think that's really important, and we've heard that through the consultations, and I think that really came through in the surveys. There also needs to be a follow-up for children diagnosed with hepatitis B to understand some sort of investigation. Again, we don't understand why children are positive. Is it because they didn't get the vaccination on time? Is it because they did receive the vaccination, but for some reason it didn't work? Or are there some sort of improvements we can work with hospitals? So there's a lot of unknown in this area. And also exploring barriers to HBIC stock out and improving communication between services as well as data recording, reporting and evaluation. Because we know if something is not recorded, then it's really hard to evaluate or to actually measure and benchmark it. I think there's a great opportunity to support and work with our workforce in terms of supporting healthcare providers, both in the community and hospitals, and also supporting community in terms of, particularly for women with hepatitis B, emotional and social support during diagnosis and post-care for them and for the children. That's the end. Thank you.